So in this lecture, we're going to talk about pneumonia. So pneumonia is an infection of the small air sacs of the lungs, your alveoli, and the tissues around them, and is one of the most common causes of death worldwide. Often, it's the final illness in people who have other serious or chronic diseases. So pneumonia may develop in people living in the community-acquired pneumonia, or abbreviated as CAP, or in the hospital setting, hospital-acquired pneumonia, or HAP. For example, a community-acquired pneumonia is more likely to stem from infection with the bacteria Streptococcus pneumoniae. And then with the hospital-acquired pneumonia, it's more likely to be caused by Staph aureus or some other type of gram-negative bacterium, like Klebsiella or Pseudomonas. I'm sure you wanted to know which bacteria causes what. So really, by the studying, community-acquired pneumonia occurs in patients who have not been hospitalized or living in a nursing home within the past 2 weeks. Nosocomial pneumonia occurs in patients 48 hours or more after their admission. You have your ventilator-acquired pneumonia occurring more than 48 to 72 hours of endotracheal intubation. And that's it by the setting. Now, by physiological location, you have your lobar pneumonia, bronchopneumonia, or interstitial pneumonia. Classifications by the pneumonia pathogen is either bacterial or viral. Let's see here. So it can be either bacterial or viral. Bacterials mostly caused by the organisms in the upper respiratory tract that are transmitted, usually by droplets, or let's say if your patient has a poor cough reflex or they have damage to the lining of their airways, that usually facilitates the aspiration of the pathogen into the lower airways. For viral pneumonia, this also starts in the upper respiratory tract and it migrates to the bronchioles, or the pathogens enter through the upper airways and then somehow makes it to the lower respiratory tract, like measles. Most common viral causes are the influenza A, B, or C, RSV, respiratory syncytial virus. Let me write those down. Common viral. So you got your flu, RSV, parainfluenza, coronavirus. And then you also have the fungal infection in your lungs. Most common in patients with a suppressed immune system, such as age. Let's see. I'm going to do a quick pathophysio of pneumonia. So pretty much when the pathogen reached the alveoli, they pretty much already evaded the physical defense mechanisms that we have. And so pretty much what happens is that your macrophages are in hyperdrive production that produces this exudate that fills the infected and neighboring alveolar spaces, causing them to stick together, and then pretty much your alveoli spaces are useless. They become airless. Oh no! How can that happen if your alveoli are airless? How are you going to have oxygenation? Not a good thing. So then that kicks up your inflammatory response to come up, and then you're going to start developing pleural effusion that complicates, like, if I recall, 40% of cases in pneumonia. And then you have reduced gas exchange. So as a result, your vital organs become oxygen deprived, and your respiratory effort is like increased with each breath. And even though you have increased respiratory and heart rate, you will have falling oxygen and rising carbon dioxide levels. Let me write that here. Increase in carbon dioxide levels. So if you see my little picture here, a couple lower respiratory and pleural diseases, you got empyema. That's the exudate that I was referring to. Pretty much you have all this lovely green gunk around in your pleural cavity. Not good. There's that sticky stuff that's not gonna allow gas exchange. And then this abscess, this big dark hole. So you got a hole of just pus, killing off all of your oxygen supply to that specific area. Then what happens? No supply, dead tissue. Bronchitis, inflammation of the bronchi. Let's see. It says here that it could be immune-mediated, like asthma or COPD. Could be infectious, but also usually viral. Let's see, bronchitis up here in your bronchs. I'm gonna make that nice and purple here. It's happening in the stems. Inflamed stems can't reach out to your alveoli. Bronchiolitis. Inflammation of the bronchioles. Also often viral. These little guys here in the little branches. Branches that perform the gas exchange. Itis, inflammation, bronchioles, no gas exchange. Some risk factors for those developing pneumonia. Age. It's either you're going to be very young or very old, and you're going to have an increased chance of developing pneumonia. Very young population have immature immune systems. They pretty much lack any antibody building exposures, and the very old have weaker immune systems and more problems with coughing and their gag reflexes. Those who are immunocompromised due to underlying chronic diseases such as AIDS, sickle cell anemia, diabetes, COPD, they're part of the risk factor. Smokers, asthmatics, alcoholics. Pneumonia usually follows an recent history of upper respiratory tract infection. And of course, our elderly population who are in the facilities are also at increased risk. So right here, I have the typical community-acquired pneumonia presentation. It can vary depending on the pathogen, but the classic and most common symptoms of pneumonia is a cough that produces sputum. Gentleman's coughing, cough, 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 cough. Sputum, bleh, bleh, bleh. Other common symptoms include chest pain, chills, fever, shortness of breath. They could also be kip nip, intercostal retractions, crackles, and cyanosis. So if you do a physical examination or a head to toe, if you listen to their lung sounds, because it is now fluid filled, right? The lungs are now fluid filled by either exudate or from their pleural effusion. So you have dullness to percussions, decreased breath sounds, crackles, rhonchi, and egophony, where now your E sounds sound like A's. Viral pneumonia usually is commonly seen in infants, such as RSV, and also the elderly. The flu virus can create pneumonia in healthy people and can pretty much happen at any point in the lifespan. Viral pneumonia is usually seasonal. Viral is seasonal. Starting with rhinorrhea, cough, and a low-grade fever 3 to 5 days. And then it spreads down to the lower respiratory tract. How do we diagnose viral? Clinical presentation, labs, and imaging. So treatment for viral pneumonia would be, I guess you could take the antiviral medications and vaccination. As for bacterial pneumonia, I mentioned this earlier, it could be based on the specific bacteria. So you had streptococcal pneumonia or staphylococcus pneumonia. As far as the diagnosis, well, we're going to look at our chest x-rays. What would they say? X-rays are the most cost-effective diagnostic tool. They usually can identify infiltrates, hyperinflations, and areas of consolidation. It could also help with the location and pattern findings because certain characteristics fit specific kinds of pneumonia. I'll just give a couple examples. So chest x-ray shows multiple small abscesses, that is indicative of staphylococcal pneumonia. Patchy lower lobe infiltrates are characteristic of mycoplasmal, and if you want to get really in depth, you have the multiple lobar involvement of Legionnaire's disease. So in summary, with the chest x-ray, we should be able to find infiltrates, hyperinflation, and consolidation. As for your CBC and leukocytosis, let's see, we can probably determine by the white count, right? Because white counts equal infection, WBCs. If it's viral, you're going to see actually a normal or slightly elevated. So either equal or slightly elevated. However, they're going to be extremely increased with bacterial. There is some controversy if you want to take a sputum sample for a gram stain in culture to determine between gram positive and negative. But I guess if the pneumonia is progressing, maybe the patient does need a more guided antibiotic treatment with that specific culture and sensitivity report. If your patient is coughing out blood, having trouble breathing, maybe they did some type of What, some type of maybe a thoracentesis. So the blood, pleural fluid, or any aspirate or tissue cultures can be done. Of course, we can get the ABGs, right? How are we gonna determine if there is gonna be adequate gas exchange? This is just an up and close definition complication of pneumonia. So pleural effusion, inflammation that leads to the exudation of pleural fluid in the space. That'd be this green field right here. So if you got fluid in your lungs, you're occupying the space to inhale and exhale, right? They're not doing their deep breathing, can't get enough oxygen in, possibly retaining CO2 because their ventilations are not adequate. And then you have your empyema, purulent exudate in the pleural space. So you got a wall, a pretty much drainage, exudate, plus nastiness around your lungs. So if they're around your lungs, what's gonna happen? Well, now they're gonna start attacking inward. Necrosis and breakdown of visceral pleura. And now you have pretty much opened up a way for the pathogen to get into the pleura. And then at some point, that pathogen is going to go straight in there. I had mentioned earlier about the abscesses that could happen. So these little black holes are now making homes into your lungs because maybe all the exudate came in, decided to make a home or nest into the cavity, blocking off all the supply. No oxygen supply, no circulation equals necrosis. Associated with staph or strep infections or gram-negative rods. The most common cause of abscesses is because of aspiration. And which population is most prone to aspirate? Your young population and your old population. Now, if you notice that when you have elderly patients at the hospital and you have family at bedside trying to shove food down their throat, the family is more worried about, my 90-year-old grandpa is not eating. He's only had 2 bites of his food. That's not enough for him. Well, first of all, is that his baseline? Was he eating 2 bites? How was his appetite at home? Is that normal for him? Does he like taking supplemental shakes instead of actually eating? Have they even done a swallow eval? Can he swallow and eat? And have they ever thought of an alternate route of nutrition if they're so worried? There's been an influx of PEG tubes being, surgically placed. So it kind of depends. What is their baseline? How are they at home? Are you going to force food down grandpa's throat? Oh, they're eggs. They're soft. They can go down fine. No, they can't. So it's very important to educate your patient's family that if you have a gut feeling that this patient is at risk for aspiration that can lead to aspiration pneumonia, which can lead to a longer stay at the hospital. Please educate your patients' families. So as nurses, what can we do as far as treatment and interventions? Well, according to guidelines, new guidelines state that you need to start antibiotics within 4 hours of hospital admission. So we're going to start with antibiotics. Then, of course, you're going to obtain all your sputum cultures, thoracentesis, pleural effusion, bodily fluids, and then you're going to tailor the antibiotics to the specific pathogen. If your patient is multi-drug resistant to the pathogen, you're going to have to use, or the doctor will prescribe and you will administer a combination of drugs. All patients must have they must start with IV antibiotics first and then transition to PO. Or if they can't do PO, then we can go ahead and do parental. Let's see. You will notice that the doctor will always favor the shorter duration of antibiotic. Favor duration. So, shorter. Usually 14 to 21 days. And, of course, educate the patient or family to monitor symptoms with awareness of the time expected for improvement with the antibiotics. Let's see. You can also educate your patient and their family to not stop the antibiotic if and when they are feeling better. Once they start the antibiotic, it's going to start creating resistance. Should they miss a dose, do not double dose at one time. Just take the next scheduled dose. Okay, so nursing assessments. What are we looking for? What are we looking for? We talked about it already in the beginning. I'm just going to reaffirm it. We are listening for what are we listening for? Name at least 3 things that we are listening for. 1, 2, 3, 4, 5. Rails, crackles, rhonchi, and then note where. What are you going to feel for? You might even feel for phlebitis. So that happens right when the chest wall vibrations are created when the patient speaks a repetitive phrase. Now, back to our objective, back to our interventions. Of course, we're going to start with the, let's keep that airway, right? Airway. Provide that respiratory support. Do they need supplemental O2? Prevent the spread of infectious disease. Your patient has RSV. Check your policies and procedures. Does this patient need to be on droplet precaution? Always maintain lots of fluids. What did I say in my previous video? At least 2 to 3 liters of fluids, please. Of course, you're going to keep them comfortable from the pain, fever. Monitor your lab work. maybe you can be assertive and watch out for expected improvements, or if they're not improving by the usual time, notify your doctor. I know we all want to snuggle up and stay in bed, but please promote progressive mobilization. Get up and walk around. Have them walk around the room back and forth a little bit. Maybe they can, encourage them walking to the bathroom if and only they are stable enough to walk. We don't want any patients falling, please. As we all know, if you mobilize, you can move your secretions along, and if their cough and gag reflexes are good, they should be able to export it. Let's see. We're going to put our patient in how many degrees? Head of bed? Head of bed. Head of bed is usually at above 45 degrees. Give that respiratory support, right, with that nasal cannula, like I said. Should they need a ventilator mask or a non-rebreather? Another side note with the non-rebreather, please flush the oxygen delivery all the way open. It's not going to work, or the non-rebreather is not going to work or be effective if your oxygen level delivery is at 4 liters. It needs to be flushed open. What are other nursing care interventions that we could do? Let's see, we did the positioning, we did the respiratory support. If your patient has some discomfort while coughing, they could always use pillows for splinting. We could have the patient use the incentive spirometer, or IS, to facilitate and promote deep breathing and coughing. So with patients with COPD, they could use the huff cough. So COPD, huff cough. And the reason for that is so few breaths are taken with less than a full inspiration that precedes the cough. There is also a controversial practice, and that is postural drainage with percussion, also known as chest PT or CPT, as it could be harmful to a specific population of patients. So back to the huff cough. You want to do a series of mini coughs to loosen and dislodge phlegm. This technique produces a soft exhalation sound, like the word huff. Sound it out, huff. As the huff cough is produced, phlegm is dislodged, and then it can be expectorated. So what are the signs of improvement you're looking for? Let's see, pretty much the normalization or the patient's baseline of vital signs, particularly a lowering of the fever. Did they break the fever? ABGs showing improved oxygenations. Your lab values are going to be more normalized WBC counts. And if and only they do another set of cultures, there's going to be a decreased bacterial growth in the cultures. So the biggest thing that we can do as nurses: promote prevention and self-care. I am a huge believer in self-care. If you'd like to know what I'm talking about, it's Orem's self-care theory. Do yourself a favor. Take some time, read that. that could be your philosophy too. So, vaccines. Number 1, prevention, vaccinations. So this vaccination is recommended for people at high risk, such as 65 years and above, younger adults who have lung or heart disease, and immunocompromised, if their treatment allows it, because there are certain immunocompromised conditions that cannot have certain vaccinations. So let's see. The protection from vaccination may last a lifetime, but it's also recommended that people at the highest risk be revaccinated every 4 years. So if you notice anything, or if you notice in the guidelines that if you are 65 years and older, you do need the pneumo vaccination every 5 years. Which population cannot receive the pneumonia vaccination? That would be your pregnant population. As for the flu vaccine, let's do red. Your flu vaccine. Let's see. Annual influenza vaccines are recommended for us healthcare workers, older people, and people with chronic medical conditions. So they should take place every year during the fall, annually in the fall, because remember, it is usually a seasonal. Let's see. So why do we have to do it every fall? So that levels of the antibodies will be highest during the peak influenza months, which is usually through November until March. A different vaccine is introduced every year based on predictions. I say it again, predictions of which strains are most likely to cause influenza. So, in conclusion, pneumonia is, you're most likely always going to have a pneumonia patient on the floor regardless of the time of year. Many end-stage disease processes in the elderly culminate in pneumonia. So, but then there's also the fact that the vulnerable population and exposure to the pathogenic agents can be prevented. So public health recommends for immunization. It is highly important. So get your vaccinations to protect your community.